kind of virtual sessions, talks, lectures, whatever, interactive sessions pertaining to our newly formed paediatric AMS network. And actually, it's been really interesting drafting this and last week's talk, actually. I mean, diagnostic stewardship isn't something that I've thought quite so explicitly about till our discussions last week. And similarly for IPC, I think there's a lot of mystery, a lot of misconceptions and things, and hopefully we'll be able to talk a bit about some of those and really promote collaborative working, which is what this whole network's about, and share good practice. Okay, let's see if I can change. Okay, so there's not much in the contents, and yet there are lots of things to discuss. So I'm going to try and break it down into kind of these three areas. One is a bit of a background around nosocomial infections. Lots of people we have very kindly have had a number of you who are IPC nurses joining us this afternoon. But for people that don't work in IPC, I think that there's one area where there's very little teaching and training for people that don't do this regularly. So we're going to do a bit of a background about what this nosocomial infection, healthcare associated infection business is all about, and also the size of the problem in paediatrics, and actually where we should be focusing our energy and our collaborations to kind of have the biggest impact. We work in a far from perfect system, so we need to think about which battles to which things that we should try and tackle. And then in light of that, and I'll hopefully be able to justify why thinking about neonatal bloodstream infections, especially central line associated infections in neonates, and all of the hospitals within our network manage neonates. Some centres are level 3 units, those that manage the most premature babies, the most complicated babies, often needing the longest inpatient stay. Some are level 2 units, they still have babies with central lines in, UACs, UVCs, long lines. So these are a problem across all of our hospitals. So rather than talking about things that are just specific to a children's hospital, that are specific to PICU, I don't think there's much of a benefit of that. We are having different discussions actually actively with our PICU about IPC practices, but this will hopefully be more relevant to the people on the call. And then something that's highly relevant, and that's to do with respiratory viruses over winter. And we've seen an uplift in flu cases in the UK in the past 2-3 weeks, especially in young adults and young people, and that's is going to rapidly extend into slightly younger children and older adults. So this is highly relevant for protecting ourselves as healthcare professionals that work with children, and also the children that we admit to hospital. And there'll be quite a lot of chat about that. And this still falls under the umbrella of antimicrobial stewardship, because if we spread things like flu in the hospital, well, then some of those children will get a bacterial secondary infection. Even those ones that just have flu, unfortunately, a proportion of them would be treated with antibiotics whilst the diagnosis is unclear. And when people suspect a bacterial secondary infection, obviously some of these things that spread in hospitals, that we have these IPC practices in place for a spread of nosocomial infections, and invariably they are more resistant bacteria than things that are required in the community, because we almost have a petri dish of infections within our hospitals. And so we kind of amplify the noise, and that noise is resistance as well. So, and most importantly, it's to do with patient safety. And I think this is the golden thread across all 5 of these talks, is that although we can focus on a little niche bit like antibiotic prescribing or even AMR, which isn't niche but is still a kind of topic, actually the big picture thing here is patient safety, and everything we're doing in all of these talks and what we're doing with our network, if it's not impacting on patient safety, we probably shouldn't be focusing on it. And so, just for definition's sake, but I think it is important for people to know what we're talking about, healthcare associated infections, there's a kind of definition that relates to time, predominantly for bacteria. It's a little bit different for our respiratory viruses. I'll talk about that in a moment. But these are infections that become apparent at 48 hours or more after hospital admission, and up to 30 days following discharge from inpatient care. So if you develop an infection at 39 hours into your admission, or 28 days following discharge from hospital, that will be labelled, if data are being collected on that, as a healthcare associated infection. We don't talk about hospital acquired infections so much. If we can, it seems a little bit kind of critical. This is to do with our entire delivery, and many of these principles also fall into other settings that aren't necessarily hospitals. They might be long care settings, long stay settings, etc. So the principle is that it actually the patient didn't have it when they arrived in hospital at time point 0, but any point after that, which could be time point 6 hours, they were exposed to something in the hospital, and then that incubation period takes them over that 48-hour tipping point. And so just graphically represented, you're at home, you get admitted, and then you're in hospital. And if you think about that, that's the 48-hour point. If your infection presents either at home and then you come to hospital because you've got meningococcal sepsis, well, clearly that's a community acquired infection. Actually, even at 24 hours, if you came in with DKA, say, and you become septic at 48 hours with strep pneumoniae, well, then that would still be counted as a community-acquired infection. But anything diagnosed at 48 hours or present or diagnosed at 48 hours post-infection is a hospital-acquired infection. And this takes into two concepts. One is colonization. You may actually be colonized with the bug before you got there. So it's a little bit tricky, say, with MRSA. If you're known to have MRSA and then you get an MRSA bacteremia after that, whereas that's slightly different. But this is kind of the concept of 48 hours. And we have reasonable data, and I don't think we've got great data to some extent. The reporting of certain types of healthcare associated infections is pretty good. And then we also conduct point prevalence surveys, and a point prevalence survey was conducted in Europe in 2022 and 23, and we then replicated this process in the UK post-Brexit in 2023 using the same methodology as used by our European colleagues. And the European data was published in the ECDC report. That's the picture there, and you can see that there are a lot of infections. 4.3 million healthcare associated infections per year were estimated across the EU and the European EEA, and the kind of prevalence of healthcare associated infections, hospital acquired infections in this case, because this was a point prevalence survey conducted in hospitals, was 7.1%, and so it was high. But we in that talk I gave about AMR, we actually did have to spend a bit of time thinking about, is any of this relevant to children? Well, it is relevant to children. So the data from the point prevalence survey in Europe and across the UK included adults and children. And from that EU data, they calculated that about 1,000 deaths a year in neonates are directly attributable to healthcare associated infections. So pretty much all of those are avoidable deaths. All of those are almost never events to some extent. You shouldn't have a baby dying of healthcare associated infection, bloodstream infection, and we yet have over 1,000 across Europe. And also the burden of AMR sits very much with nosocomial infections, with healthcare associated infections. And that in turn leads to this vicious cycle of getting exposed to, getting colonized with a nosocomial infection, that then resulting in infection, which could be a CLABSI, so a central line associated infection. It could be a ventilator associated pneumonia or hospital acquired pneumonia, or it could be a UTI associated with a catheter. But those conditions then need treatment with antibiotics. And then by virtue of giving antibiotics for something that may already be quite resistant because it's a healthcare associated infection, you're then driving further resistance and further acquisition of nosocomial bacteria. So it's just a terrible scenario. So it's a bit like vaccines. You want to try and put in a preventative thing in place, and that's where I see IPC massively. If we can avoid these children getting their nosocomial infections in the first place, well, then we have a massive downstream effect on these children and antibiotic use and subsequent development of AMR. And the other problem with healthcare associated infections, or in this case, hospital acquired infections, is that their numbers going up. And so compared to their previous point prevalence survey conducted in 2016, there's been a significant uplift in prevalence in hospitals. And that could be for many reasons. And I don't think they have speculated on what they are, but we could speculate. And that could be that patients are more complicated now. It could be that staffing levels are worse now. It could be the financial environment's worse now than it was. So, it could be a whole array of different things. But the problem in adults and children is bigger now than it was 10 years ago. And when you actually, we spend a vast amount of time as healthcare professionals thinking about infections, and that column on the right, that long column, it's a whole variety of different infections that we may know something, a little or a lot about. We may have seen some of these cases or not. And yet numerically, when we look at the burden of community-acquired infections, which all of those on the right are, with healthcare-associated infections, actually we're dwarfing the number of community-acquired infections by these healthcare-associated infections that adults and children acquire in hospital, kind of double the burden. So it's massive, actually. And here are some of the granular data conducted from the UK point prevalence survey. So this was, as I said, conducted in 2023. And these are prevalence rates for healthcare associated infections. It was estimated at about 18% on PICU. And so the highest prevalence across our entire paediatric population. So, that's why I and my PICU colleagues and microbiology colleagues are putting in a lot of work on trying to tackle that on PICU. However, neonatal units, which are in all of our hospitals, still have a prevalence rate of 11%. Clearly, it's slightly different in a tertiary unit compared to a level 3 unit, compared to a level 2 unit. But that numerically in paediatrics is that where the biggest burden of healthcare associated infections lies within a paediatric population, as you can see from those numbers. And when you delve into what those healthcare associated infections were in those neonates, you'll see a lot of that bar is pink. And that pink relates to sepsis and disseminated infection. So we're not talking about some little skin infection they're getting or a little bit of a gastro thing. We're talking about a life-threatening infection, which is happening to a significant number of neonates managed up and down the country. So this is why some focus needs to go into this. And this is a slightly messy slide, but I find it interesting because it's to do with age all the way up to adults. And so when one thinks, when people derive strategies for IPC in hospitals, they think about the big three, and the big three things are lower respiratory tract infections, so VAPs and HAPs, so ventilator-associated pneumonias and hospital-acquired pneumonias. They think about catheter-associated UTIs, and they think about CLABSI, so central line-associated bloodstream infections. Well, when you look at these data, you'll see that the VAP, the kind of respiratory and the UTI-related hospital-acquired healthcare-associated infections, the burden very much falls in adults and actually very little in children. Clearly there is some, and we see VAPs, or what are defined as or treated as VAPs on PICU relatively commonly. But the big difference is that the burden of CLABSIs and bloodstream infections massively falls in the paediatric population and massively in the very young paediatric population. And you see it in this graph. So this is a graph of just the paediatric age bands in these columns. And the red is bloodstream infections. And you see that there's this very clear trend as you maneuver through pediatrics, your risk of bloodstream infections, and this is all healthcare. So this isn't community-acquired infections, to clarify. This is only data on healthcare associated infections. And that's why you can hopefully understand why putting some thought and energy and passion into tackling CLABSIs and healthcare associated bloodborne and bloodstream infections on our neonatal units is a very worthy endeavour, because it is a massive problem, and you're better off putting that energy there than in children on your general peds wards, because for your bang for your buck, that's where, and these children, that's where they're getting them, and they're getting them because they've got slightly immature immune systems, especially the extremely premature babies. You've got rubbish skin, your skin integrity is rubbish. You're in this kind of incubator thing that's this lovely breeding ground, potentially, and nice and warm. You're in for a long time. You've got tubes and lines in every orifice going and multiple reinsertion of things, unfortunately. You've sometimes got awful estates, and any of you that have been to Southampton have seen our previous NICU. It's kind of being rebuilt, and some of it's considerably nicer, with much more space between babies. But we used to have, literally you would turn around and you'd be knocking into the ventilator behind you. You'd be turning on a sink and it'd be splashing onto a ventilator. This is totally, the estates can be dreadful for some of these neonatal units. And then we've got long periods of central access, and these lines that are extremely precious because it's very hard to insert them, and babies whose guts are so immature or they develop necrotizing enterocolitis that they need very long periods of TPN. So this is a perfect storm, and probably explains the data on that slide, why that red bar is just so massive. Nearly more than 50%. 50% of no healthcare associated infections in neonates is due to bloodstream infections, which is just awful. For our IPC colleagues on the call, the other big difference between pediatrics and adults is to do with children. Children are very mobile often. They'll run into playrooms. There'll be an element of chaos in playrooms, very hard to keep these areas kind of clean. You've got multiple, instead of maybe one visitor, you may have siblings, you may have parents, grandparents. We're very reluctant to restrict visitors to pediatric wards because we've still got to deliver humane care, especially at a time that these families are feeling so vulnerable when their child is sick. But this adds an extra dimension. You then got to think about toilets and kitchens and all sorts, where you can get areas where there is significant spread of infection within a healthcare setting. And so just, our IPC colleagues are totally au fait with this, but many of the rest of us aren't. And some of these terms we find confusing. Standard precautions, transmission-based precautions. We'll talk a bit more about transmission-based precautions when we talk about respiratory infections. But standard precautions are basically what you do every time you see a patient. And if you're going to be exposed to body fluids, you need to ensure that there is not a chance of you then collecting a bug from the patient and taking it on to the next patient that you see, or back home with you, potentially to a loved one at home, or to yourself, to then basically get something in your eye that will then make you unwell, or etc. And so those standard precautions we need to think about for patients where we do not believe they have an infection, but there is a chance of getting infection, acquiring an infection or being colonized with something as a result of one's proximity to the patient and the cares one is delivering. Transmission-based precautions are different. They're on selected patient, depending on what kind of infections they have. And we talk about contact, we talk about droplets and airborne precautions. And this relates to how different pathogens, different bacteria and viruses spread. And depending on that modality of spread, there'll be some kind of barrier for your hands, potentially, for your clothes, for your respiratory tract, for your eyes. And that will be either masks of some sort, which may be fluid-resistant surgical masks. There may be FFP3 masks or respirators. There'll often be eye protection. There will be hand washing, obviously. There may be gloves. There'll be an apron. There may be a larger gown, etc. And for our most infectious and worrying pathogens, which are high consequences infectious diseases, there'll be an even greater level of PPE that's required there. And those transmission-based precautions involve special boots, donning and doffing areas, and all sorts. But the basics, which are on this slide, get your PPE kind of right to avoid you infecting yourself and then or colonizing or getting bacteria on you that you can transmit to another patient or to yourself. And we tackle these by sort of breaking it down into the environment, into staff, and into visitors. And the biggie is hand hygiene, and we'll talk a bit about hand hygiene. I obviously just spoke a little bit about PPE. When you're unwell, to not be in these situations where we may infect others. People have become much better at wearing masks if if they've got mild respiratory symptoms. For visitors, it's to do with screening. I'll talk about that a bit more at the moment. And then the environment, I think, is one of the places I find hardest to kind of conceptualize. But clearly, the way we clean our environments after a child has been in a bed, in a cubicle, etc., and obviously the way that we monitor the air in those areas has become very clearly better understood since COVID. And there's an understanding of number of air changes per hour in certain environments that then reduce the risk of us getting sick. So if pathogens are hanging around in the air when we go into these cohort areas to manage children, well, then that is a problem, even if we're wearing what is regarded, as appropriate PPE. So then we would potentially have to think about uplifting our PPE if the estates and the ventilation in those rooms is not doing the job that it's supposed to. So all of this is a kind of balance of things, some of which are out of our hands. And that's because of this iceberg effect. So you've got a patient who comes in with diabetic ketoacidosis. You don't know if he comes in with group A strep. That's easy. He's infected, and you're going to hopefully implement the right IPC measures. If he comes in with a respiratory tract infection, you're going to hopefully do something similar. That's not definitely definitely the case, actually. And when we audit IPC practices, we unfortunately find things that aren't necessarily supporting trying to reduce that spread. But it's much harder when patients are colonized. The thing under the water, the iceberg effect, there's far more of an iceberg below the water, obviously, than above the water. And so if you don't do proper IPC practices, and I'll talk a little bit about proper IPC practices in a moment, but clearly hand hygiene is our most effective our thing that we do when it comes to IPC practices. Well, then you can take an organism from a patient unwittingly and bring it to our patient who's got diabetic ketoacidosis, who's got lines in, who might end up being so sick that he ends up on ITU, PICU, being ventilated. And unfortunately, when he's then ventilated, firstly, if we've colonized him, and that colonization can happen at any point, as soon as they're admitted, then at some point after that, which would be 24, 48 hours, anywhere after that, if they've got a line and a central line in, that might then result in a eclampsia. If they've got a tube in to ventilate them, they might get a VAP. If you've got a urinary catheter in because you're obsessed with measuring urine outputs on this child with DKA, they might develop a catheter-associated infection. And so, and that in turn then results in antibiotic prescribing and mortality and morbidity risk. And clearly there is a mortality with bloodstream infections that's not negligible. And when we look at these environments, and this is a lovely piece of work done where people, swabbed an environment, and this is a bay, a bed in a bay, it looks like. Slightly funny sink there, but they swabbed the hands of staff that were managing this patient who was vancomycin resistant enterococci positive. They swabbed the environment as well, and you can see that there's just VRE all over, from various environmental surfaces. It stays for up to 7 days on a countertop. It was on the hands of staff. So it's impossible, pretty much, when you're managing a patient like this, to not be exposed to the pathogen that the patient has. However, and this is why we are obsessed with getting the kind of PPE and the hand hygiene right, is that when you manage these children or adults, even after you take you wear everything properly, 40% of them, when you look at that picture, I'm surprised it's not higher, but 40% of people who manage a patient in that environment ended up in this study with that pathogen, that bug on their gowns or gloves. So it shows that there is almost always exposure. even after removing gloves, 5% still had them on their hands after glove removal. So that's telling us that hand hygiene is so important, because you are highly likely, and then that just becomes like a pyramid scheme, and quite rapidly you get massive spread of these bugs in a hospital. And I hadn't seen this slide until recently, and it was presented by a colleague when I was out in Spain recently. And what it shows is the bacterial reduction, so that the higher that line, the better. And it's not it starts at 90%, so it's a logarithmic scale, but it's not at 0%. Well, it is zero, but it can't be zero, because zero is not on a logarithmic scale, but it starts low. And so when you look at soap, if you're just using plain soap, the impact on bacterial reduction on your hands is lowish. Even when you just use antimicrobial soap like 4% chlorhexidine based soap, which is you've got a reduction of somewhere less than 90%. And actually, things like hand rub are probably our most effective way of decolonizing our hands that we have available to us. So, this combination of washing hands, using alcohol rub, is a highly effective way of hand hygiene. And that's our most effective way of transferring pathogens from one patient to another. And then some other terms just for information: source control, protective isolation. This is how we use our cubicles. So if we have a patient with an infection, and we have to prioritize which patients with infections go into cubicles. And so if you've got a norovirus, something that's highly infectious, they need to go into a cubicle for source isolation. Also, our most resistant organisms, so some of our carbapenem resistant bugs, they would be prioritized into a cubicle. We sometimes, for the most transmissible cases, so that measles, or ones with significant implications like XDR and MDR-TB, would ideally want to put them in a negative pressure room, so that there's very little chance of those pathogens getting out of that environment if they become aerosolized. And these are for airborne pathogens. And on the other side, the other reason we use cubicles is for patients that don't have infection, but where the repercussions of them getting an infection in hospital is massive. And that can be our most severely immunocompromised children. And for some of the most exquisitely susceptible patients, we may, if we have these estates that have positive pressure rooms, and they do on our bone marrow transplant units, they'd be in a positive pressure environment, so that the things are pushed out of their room constantly. So there's very little chance of things from the outside coming in. I briefly mentioned gastroinfections. I'm not going to say much of them, except that they can cause chaos, and everyone on this call knows how much chaos they cause each autumn and spring, often with norovirus outbreaks, and then rapidly move across wards. That's why isolating these patients rapidly, implementing proper PPE, proper signage outside doors, educating people on what that signage means so that they adhere with the PPE, conducting spot audits, and really doing this is essential if you want to try and limit the amount. These patients will come in because it's in the community. What we're talking about here is how do you limit its spread within a hospital setting. Rotavirus also similar. We've had far less rotavirus in the UK since we've implemented the vaccine, but there is some risk that as vaccine hesitancy increases with people like Kennedy, etc., in positions of power in the States, and people believing social media threads, that we'll see, and we are seeing increasing issues with this. And to note, this is a situation where alcohol gel is not effective. So that was a bacterial graph. For norovirus, do not think that graph applies. You need to wash your hands, using appropriate cleaning techniques. And it's all relevant because we can make a difference. I mean, if all of this was just, we can't do anything about it, these things are going to spread, it would be a bit of a pointless talk. But the point is that we know that about half of our healthcare associated infections are preventable. And that in turn, if we prevent them, then those children don't get antibiotics, we don't drive increasing AMR, we don't create a greater ecological niche for nosocomial infections. And that's that vicious cycle that I showed before. And and this is the kind of death thing, you know, in low, this is a graph published last year on low, middle, upper, and you know, various different countries. So low income, upper middle income, and all LMICs together. And you can see that, you know, IPC has a significant impact in reducing deaths. Access to clean water and sanitation, which is WASH, has a large impact. And obviously vaccinations have a large impact as well. And this is the role at this point in time. So, you know, IPC measures have a huge impact in mortality globally, especially in low and middle income countries. So, you know, that's the sort of background to healthcare associated infections in children. Let's talk a little bit about neonates and catheter central line associated bloodstream infections, so CLABSIs. And these things happen either when the catheter is inserted, when the dressing's being changed, or when the catheter is being accessed. And so our approach is to try and reduce, and actually before I say any more, I think the most important thing is to have a handle on your CLABSI rates. And we in Southampton are absolutely awful at that. I haven't routinely scrutinised CLABSI rates at any point in my time in Southampton. We're now addressing that, and we're going to have a regular review of all CLABSIs and CLABSI rates on our neonatal unit and PICU for the exact reasons as I've said on these slides. But the things, if you notice a problem, and even if you don't, things that you need to try and tighten up on to review CLABSI rates is you know, prevention of transmission, so hand hygiene, reducing risk, you know, the exposure. So actually, does the line need to be in? Did it ever need to be put in the first place? You know, so daily review of need of central lines, that obviously on long lines, UACs, UVCs in our neonates, especially the UVCs, which are more likely to get infected than the UACs. And then preventing this colonization, contamination, and invasion. So when we put them in, that we put them in aseptically, that we change dressings aseptically, and we don't use lines just, you know, willy-nilly. You know, the more times you use your line, the more likely you are to infect it. And these are the kind of you know, you kind of got to do all IPC. Very unlikely to be able to implement every IPC measure on a wish list for many reasons. One is our estates, one is you know, buy-in, and also so you've got to work out where your biggest bang for your buck is. And clearly, one of your biggest bangs for your buck is not putting in a central line if it's not needed, then taking it out as soon as possible. You know, these are our two biggest things if you want to reduce CLABSI rates. But then, you know, the things that we put a lot of, in theory, energy into, which is bundles. So how you use your bundle to put in central lines in aseptically, and then trying to avoid and contaminate them. So that's the kind of order. And this isn't quite a hierarchy of controls, but I'll come to this concept of hierarchy of controls in a moment, where you kind of have to kind of stratify the work required and the impact of every intervention to work out actually which order you do things in. Right at the bottom is using antibiotic impregnated lines and there is aseptic compounds and stuff. You know, these shouldn't be necessary if you do all the basics properly. If you do everything before this properly, there's very little added value. And this is essentially an added value graphic that you know, it's the law of diminishing returns as you go down this list. And so we have loads of guidance. There's guidance coming out of our ears for everything. So I don't need to tell you about guidance, but, you know, there's this group called SHEAR, who are an American-based group that work with the IDSA. So that's the American ID Association, that have developed some really nice guidance for central lines. You know, clearly not going to go through this, but they talk about before insertion, at insertion, and after insertion. And they break it up very nicely into kind of some evidence-based things you should be thinking about and doing if on your unit you manage children with central lines. And so this is the kind of thing that we should be thinking about in terms of auditing across all of our units. You know, do we kind of align with some of these and these are just the essential practices. You know, if despite implementing all of this, you're still having a big outbreak with something or still issues with central line associated infections, you might move on to the kind of the the next step of practice, but you can't do phase 2 if you've not done phase 1 properly. These are our kind of biggest bang for your buck, easiest to implement at lowest cost kind of implementations. You do this properly, you shouldn't have to then go on to the much harder stuff when it comes to, you know, zapping morale of your staff and bleeding your department dry financially. So you know, there's something about you know, are we doing this on an and I don't think we have any idea, to be entirely honest. We definitely don't in Southampton have much of an idea about CLABSIs and CLABSI rates. And then there are other bits you can do, and this is some interesting stuff about chlorhexidine. Many of you will know that there's some nice evidence, and this is in children actually and adults, that if in intensive care settings, this would be PICU, say, or NICU potentially, I'll come to NICU in a moment, that if you kind of wash patients with chlorhexidine daily, you have a big reduction in CLABSI rates, a very marked reduction in central line associated infection rates, as well as other nosocomial infections. And so there's something in that. You know, I'm not even totally sure we do this in Southampton on our PICU for every child on PICU. We try to, and whether it's actually being done is another question. On neonates, it's a little bit more complicated. You know, there are things you can do with CBC dressings, but this use of chlorhexidine is a bit more complicated because it is absorbed by the skin in neonates, especially our most premature neonates below 20, I mean, we say below 37 weeks gestation. It's generally not recommended to be putting chlorhexidine on the skin. But, you know, our slightly older babies on neonatal units who have got lines in, we definitely should be thinking about how we can put things in place to reduce the risk of central line associated infections. So I'm just going to finally move on to something that is highly topical and relevant at the moment, which is respiratory tract infections. And these make up a significant proportion of healthcare associated infections in children. I think that we really struggle to have any idea of what the real burden is of these infections because we don't have any way of monitoring who's getting infected with a second bug in hospital, because partly they then get discharged home relatively quickly, and if they then deteriorate a bit or have symptoms at home in the 30 days afterwards, we'd have no idea. But, you know, these do clearly, when people have tried to look into it, there is a big burden from respiratory tract infections. So I would not be taking these lightly. And I think historically I have taken them lightly. And I thought, well, you know, you get them in hospital, or you get them in hospital. You know, we can only do so much. You know, they needed to be here. But I've really turned 180 degrees on this opinion. This table here is just a slightly complicated table. It's to do with definitions of hospital-acquired healthcare associated infections for these respiratory viruses. And it's not necessarily, at least for in these American definitions, it's not as clear-cut as 48 hours for some of them because of incubation periods and things. But the bit I think that is more relevant here is that for children who get infected with, say, this for RSV in hospital, they are far more likely to have a worse outcome than if they acquired RSV in the community. And so your need for respiratory support is much higher in children who have a nosocomial RSV infection, as well as their rates of PICU admissions and significant mortality. And this is why we do need to put a little bit of energy and focus into reducing the risk of respiratory viral infections in hospital settings. And that's why I chair a group in the Royal College of Paediatrics and Child Health that's just updated this guidance. This is pretty much hot off the press. It still needs to be finalised with the rubber stamp from the president of the college. The first time we wrote this guidance was in 2021, and we review it and update it every 2 years. So this is kind of the recommendations and the changes. So as I said, the last time we updated it was in 2023. A lot of the drivers for it were the RSV surge in 2021 in Australia, and knowing that was going to come across the UK. So we wanted to put some good guidance in place to try and allow hospitals to still function whilst keeping patients and staff safe. And that safety is a twofold safety. So clearly, if we put things in place that totally stop any flow of patients through the hospital or off PICU, then that isn't allowing us to deliver safe care across a system and across a hospital where we have to have flow from ED to general paediatric wards to PICU, out of PICU to let other children onto PICU. So that's a bit of the equation. The other bit of the equation is staff. If we then have all of our staff go off sick because they've been infected with some of these respiratory infections, well, then we can't deliver safe services. If we're working on 50% capacity in our EDs or general paediatric wards or PICUs. So safety isn't just for children getting it. There's a much broader safety angle on this as well. And balancing all of these things is quite complicated. And that's what we try to do in a pragmatic way with system leaders from an NHS England IPC team and IPC frontline clinicians and paediatric clinicians, ED, etc., PICU and PEDS ID. And the big emphasis here, and it will hopefully come up numerous times, is that this document is just a bit of a kind of, as a guidance, it's a template, a blueprint for how you can do it. But what you actually do totally depends on how many beds you've got in your hospital, how many cubicles you've got, what tests you have available. And the only way any of this works is if it drives a collaboration and a discussion, ideally prior to the start of your winter respiratory season, with your paediatricians, your ED staff, your IPC staff, your virology staff, and your hospital managers, so that you can all bring things to the table in this kind of discussion, because all of these groups, and I have left off ED there, I noticed by accident, are absolutely essential in this kind of pre-planning and then bringing this group back together when suddenly you've surged your services and you've got no cubicles or you've got a total block in ED for whatever reason. This is the group that needs to brainstorm in real time and tweak the plan so that it still allows your children in your hospital to be managed safely. And so the key updates are that we've taken a different approach to COVID in 2025 compared to in previous years. And that difference is that for us to see children with COVID occupying cubicles when we're then leaving other children with other more impactful conditions or who are severely immunocompromised in open bays is something that we feel doesn't bring safety to children, especially as our knowledge of COVID in children is significant. And the knowledge is that it very, very rarely makes children safe. So it's very different to RSV and influenza. So COVID is now regarded more similarly to other viruses like rhinovirus and and adenovirus and human metapneumovirus. So it still needs some IPC practices to be in place, and these children still need to be cohorted, but they don't need to be placed in a cubicle or cohorted in a COVID specific cohort bay. And that has an impact on our estates, actually, not having to find multiple different cohort bays or additional cubicles. Isolation guidance has changed a little bit. For the majority of children, 5 days after symptom onset, you're no longer infectious. And so you should be able to be de-escalated from the isolation setting you're in, which might be a cubicle or might be a cohort bay. For flu A, it's a little bit different, flu A and flu B. So if you're immunocompromised, and the immunocompromised bit relates to all children, if you're significantly immunocompromised, there does need to be some sort of discussion with your laboratory staff, your microvirology staff, about how long isolation should be, because there is a risk of prolonged viral shedding and thus a risk to people around that child if you de-escalate too early. But with flu, if they're in a critical care setting or they're immunocompromised, it's a 7-day minimal period of isolation because of data that suggests that that's a kind of minimal period that you're still shedding a viable virus. We've kept measles guidance in there, and I'll talk very little bit about measles. Luckily for us in Wessex, we haven't had any big clusters of measles cases locally, but clearly in Birmingham, the Northwest, London, there have been bouts, periods where people have spread it quite effectively, and then in hospital settings. Pertussis, we've added information about because of its implications to children and also its high infectivity, and then the need to give secondary prophylaxis. And we've also spoken a little bit about using an audit to drive this collaboration, these drive this communication between those key stakeholders that I put on the previous slide, and to audit one's processes to check that they are sort of fit for purpose to allow you to deliver safe care over the winter months. This is a flowchart I'm not going to go through, but this accompanies the national guidance. But the bit that's relevant, most relevant, is the bit right at the top, or second row down, which is that orange. During periods of high virus circulation, cubicles should be prioritised for children at the highest risk of severe disease, and I'll talk about that in a moment. And then we'll go through some of this guidance, but it's a pretty simple, clear way of thinking about how to manage children over the winter months. Some of these core principles are that we have to deliver safe care. We've got to keep our patients, families, and staff safe. So we cannot have them infected with these bugs in hospital, because we know the implications for other patients is significant when you're getting them nosocomially acquired, and for staff, if it results in staff sickness, we're so delicately balanced with staffing levels. We also got to think about how prevention, actually, and that's where vaccines come in. We've got to try and work as hard as we can to optimize influenza vaccine uptake in staff who look after children. Children are often super spreaders of flu, so our staff are being exposed potentially more so, or definitely more so in hospital than at home. Pregnant women get vaccines against RSV, against pertussis and flu. We've really got to push that, and we have data on uptake rates from different hospitals. And obviously, childhood immunisations like the MMR is the biggest factor into whether you're going to end up with an MMR outbreak or not, is to do with MMR uptake rates in your community, and prioritising cubicles. And this is not going to be something I talk through, it's on the national guidance, but this is how we've defined the highest risk patients. And these are the ones who have got things like severe combined immunodeficiency, who are in the first 6 months post-allogeneic bone marrow transplant, or 3 months post-autologous bone marrow transplant, or 6 weeks following solid organ transplants, or first month of leukemia treatment. These have got spectacularly broken immune systems, and if they then pick up one of these bugs, these children are essentially shielding in their normal environment at home for that period. So if we then expose them to bugs because they come in with something else, that's totally indefensible. And children with CF under 2 years of age has come into that category as well. And then we've got some others which are, which if you've got cubicles available, you would house these children in cubicles. These are children who are not infected. These are well children, where you're trying to avoid them. This is protective isolation. But when you run out, if you surge your cubicles for whatever reason, say you've got a norovirus outbreak as well, then you're going to have to take some thought into whether these children, where you can most safely house them, which is why we stratified in this way. PPE guidance relates to AGPs and to non-AGPs. So for aerosol generating procedures, such as intubation, open suctioning beyond the oropharynx, but not CPAP, not high flow nasal cannula oxygen, then you need to wear aerosol protection, which is an FFP3 mask, because of the size of those droplets, the size of those particles, I mean. And you've got to protect your eyes, and you've got to protect your clothing. If you're working in a bronch bay, or an RSV bay or a flu bay, but you're not performing AGPs, the national guidance is you can wear a fluid-resistant surgical mask, as well as eye protection, clothing protection, etc. Potentially, if you're in a surge, you're in an outbreak setting in your hospital, or if you've got a surge with lots of staff going off sick, you may decide in your own hospital to implement universal masking for staff whilst they're in clinical areas. And clearly, we did that during COVID, so that shouldn't come as something people have never heard of before. The environment, this bit I'm no expert on, and I'm not totally sure who, clearly in each hospital, the person in charge of estates will know numbers of air changes, but actually it is important for people to be cognizant of this. How far off 6 or more air changes are you in the bronch bay that you're using, in the RSV bay, the flu bay, or the other massive viral cohort bay? Because if you're really far from this, you need to do something about it, because then there is a risk to staff that they're going to get infected, because your assumption when you're saying just wear a fluid resistant surgical mask is that you've optimized other bits of the system. And if you're working in a suboptimal system, you may then decide, well, actually, we might need to put all of our staff working in that bronch bay in an FFP3. This is a delicate balance of discussions that need to be made by the right people. Then testing, we really do recognize that testing brings benefits from an IPC perspective. So we want them tested if they're being admitted. We want them tested ideally with good quality tests with high sensitivity and specificity, which is our molecular tests. Some hospitals are moving or are using antigen-based tests, which have got much lower sensitivity for flu and RSV than molecular PCR-based tests. They're using a sort of two-stage system where they do that test. If it's positive, they believe it. If it's negative, they'll move on to a PCR. That's mainly for cost saving reasons, and that's totally understandable. But you've got to ensure you're happy with the system you've got in place, because the sooner you can diagnose a child with flu or RSV, the sooner you can either put them in a flu bay or you can put them in a cubicle and reduce the risk of them exposing and infecting other children and staff. During periods of high influenza prevalence, we say that for high-risk children, so these are children who would then be treated if they were positive, you'd actually consider testing them in an ED setting, even if you're not admitting them, because by diagnosing them and treating them in the community, you may then avoid them returning and being admitted and ending up on PICU a few days later. And some of us have access, all of us have access to broader diagnostic panels. We spoke about this last week. I'd only consider using these if it's definitely going to change management. So if you've got a diagnostic dilemma about the etiology of an infection, and if you have a significant pretest probability that it's viral and that would allow you to stop antibiotics, then okay. If it's not RSV, flu AB or SARS-CoV-2, you might justify doing a broader panel, but that comes with the caveats of some of those things that are on those panels, such as mycoplasma, that could give you a false, give you an idea of colonization, might lead to inappropriate, you might force your hand on giving antibiotics when they're not required. And we've just finalized this statement yesterday at our Wessex ID network meeting. So this will be circulated and put on the PEER website in the next few days, hopefully, which is some clear guidance on respiratory testing in children. For ED and PAUs and paediatric assessment areas, we're not recommending hot or cold areas. These things were put in place during COVID, but they're so disruptive for staffing, they probably have an overall negative impact on the care we deliver. We do suggest prompt triage, distancing if we can in waiting areas, respiratory hygiene being promoted to families to avoid them spreading things in the waiting area. Parents are symptomatic, carers are symptomatic, make them wear a fluid-resistant surgical mask. Clearly have a low threshold for thinking about measles when you know there are cases circulating locally. And I'm going to show you a screening and streaming tool in a moment that you could use as a starter for 10 for you to adapt for your organisation if you know that there are measles cases. A measles case being missed and left in a cubicle, left in a open in a waiting area for 4 hours and then in an open bit and a bay on a ward would totally decimate your IPC team for the coming days and weeks afterwards. So it's really important to try and pick up on this, and pertussis is not dissimilar. And so this is an example of a measles screening and streaming tool that would be put in the triage area of your ED or the triage area or the initial admission area of your assessment unit, and it will give people an idea of what they're supposed to think about. But I'd only implement something like this if you know you've got a significant number of cases in your local area, because its sensitivity, its specificity, I mean, is so low that so many children would fall into these criteria that if you use it willy-nilly and you'll not get your pickup is just going to, and people will then just switch off to this tool. For wards and HDU admissions, we've said that you can admit to a mixed respiratory cohort area until virology is known, and then but that's on the caveat that the sickest, the most vulnerable children have already been put straight in a cubicle in ED and also on the ward. So you haven't got your highest risk children in those undefined respiratory cohort areas before virology results are back. So we're definitely not saying they've got to stay in ED until their results are back. That would destroy flow in ED. We say flu and RSV are the two that require some kind of specific thought. You don't want children to acquire these in hospital where possible because of the repercussions, both from a subsequent illness, nosocomial infection perspective, and the need for giving prophylaxis for flu. And so we either put them in an RSV cohort bay or an influenza cohort bay or a cubicle, depending on capacity. If children are on high flow nasal cannula oxygen, and there's a lot of guidance about, not starting it inappropriately, it's a bit like ceftriaxone. It seems to just be doled out, and it's not a non-harm related procedure intervention, and then daily review and a clear weaning plan. And there's a very clear guidance written by the British Paediatric Respiratory Society in that guidance. And then, as I said before, when can you sort of stop your infection prevention processes in terms of thinking this child is infectious? And, I said pediatrics is different because of parents and carers. So we do have to embed daily symptom checks of parents if they become symptomatic to try and get them out of the hospital and bring in the other carer. If that's not possible, they have to wear a fluid-resistant surgical mask in communal areas or when staff go in, etc. No siblings if they're symptomatic, and they need this written down. It's got to be really clear, ideally in that bay itself, as well as written plus electronically given information. And then when things go a bit wrong, when you've got an outbreak, if you can't meet the guidance, that's when you've got to bring those leads, those people together to try and come up with a workable plan that works for your environment. And you've got to use this hierarchy of controls because none of us can apply everything perfectly. So you've got to work out where you put your energy. And this hierarchy of controls is a bit like the thing we saw for CLABSIs, is that, physically remove the hazard is you kind of top most effective, and it kind of works down and down. So you kind of work out what you can do with your most effective moving down, and your bank, you're getting a diminishing law of diminishing returns on the hierarchy of controls. And I sort of said, we've this is the third time, this is the third iteration of this guidance, and it's never been completely, I've never been entirely convinced that anyone has implemented these guidelines at all. So this year, we're really going to push, at least in Wessex, we're going to, as part of this network, we're going to ask every single unit to audit their processes for this cohort of children against the national guidance. And we produce an audit tool, and the audit tool will send round to everyone on this group, actually. And it broken down into organisational preparedness, what happens when they're presenting to ED, what happens when they come to the wards, are you ready if a child is being repatriated from PICU, what are you doing with parents and carers, what are you doing with high flow nasal cannula oxygen, what are you doing with your de-escalation and discharge processes, what is your environment looking like and the ventilation of your rooms, and what are you doing, what plans, systems do you have in place in case you have an outbreak of one of these bugs in one of your units? And actually, networks work. The reason we're pushing this across our network is that actually when networks have come together to try and tackle central line associated bloodstream infections, massive reductions. And I think we can do this for CLABSIs across Wessex, and I think we can do it for during respiratory viral season as well. I've shown this picture before, and we've spoken about an AMS network, but I think we've missed a trick here, and I don't think I'm even that keen to continue calling it an AMS network. I think we need to call this an AMR network, a Wessex Paediatric AMR network. And we have to include our IPC colleagues in our network, because only by having consistent, respectful discussions where there aren't black and white answers, where we work entirely in shades of grey, are we going to be able to tackle the issues with AMS, with diagnostic stewardship for IPC, and actually only through collaboration are we going to be able to improve patient safety and also drive down rates or reduce the escalation of rates of AMR. So I probably will stop there. I think AMS, IPC, diagnostic stewardship, we need to all work together on. And it's very hard to say any of us are linked to just one of those processes. I think we're linked to all of them, everyone within this network. And we need to work with our microbiology colleagues, our pharmacy colleagues, our frontline clinicians, and our IPC teams. And my last slide actually pertains to something slightly different, which is just a service evaluation. I'm not going to, don't have to take this as a QR code, but before we meet for our face-to-face day of workshops on the 27th, we would like each unit to have audited its respiratory processes using the tool that I'm going to send through today or tomorrow, and also to have audited what your AMS stroke AMR program looks like in terms of what it's doing in personnel. And that we will then feed those results back, and it will make up part of our workshops when we meet on the 27th. It's 1:04, so I'm just going to stop there. We started at 3:02, so probably just about stuck to time. I know that was quite a heavy talk, especially on a topic that many people haven't really thought about at all, actually. But clearly our IPC colleagues have. Judith.
Hi, Sanjay. Thank you. That was brilliant. Again, really, really inspiring. One of the things I feel like I need to do is make sure I pass all these messages on to my colleagues, and I think there are ways of me doing that. One of the things that's perhaps not quite as related to this, but it is, on the study day, the thing you brought up is giving azithromycin on the people who come back as a mycoplasma positive on the extended panel, the babies, and I think we're really bad that an awful lot, and I really want to feed that back. I remember you saying that, well, that's just not the picture of mycoplasma. Can you just expand on that for me so that I can, the younger children, so that I can feed that back to my colleagues, because I think we do that a lot in Portsmouth.
Yeah, so Judith, the good news there is that we've just finalised that respiratory testing statement. So it's all in that statement that's going to be on the PIA website in the next few days. So actually, it's not just you. You don't have to. I mean, I'm going to come back to what you first said, because I do think this group does have a responsibility to feeding some of these messages back from these 5 sessions back to your colleagues who may be paediatricians, either consultants or trainees, that may be nurses, that they may be pharmacists, they might be microbiologists. I think we have to have a way of cascading this. And I think that everyone on everyone within this network having access to these slide sets, you can then cut and paste those slides into something that you can do to deliver 1 or 2 or 3 grand rounds in all pharmacy things, bring people together.
Thanks, Sanjay. Thank you.
No, sorry. I was just getting an echo. I stopped. But the all that stuff you asked about, Judith, about the mycoplasma results, we've written that in great detail in that statement that we just finalised yesterday. So that's going to be published soon. So once that's on the PIA website, we'll send a link to everyone on this group, and then please do cascade it to your colleagues.
Thanks, Sanjay. Thank you.
Okay, any other questions from I know that was the least interactive session we've done, but actually I think there was a sort of reason for that. It's that there was a lot of stuff that's pretty novel to many people within that session. So I just wanted to get that as information. What we're going to do is we're going to add an IPC workshop. So on the 27th, we're going to have an IPC workshop that's probably going to focus on respiratory infections and how we reduce the spread of those. So that's when we're going to be able to interact and put some of the stuff we've spoken about today into practice. Thinking just more towards the future, clearly the 27th is when we're next going to meet, many of us, for our colleagues from Jersey. There's going to be that they've got a hybrid option just because of the sheer challenges for them coming over for a day and the cost of that and time implications and all sorts. So we'll be running their workshops hybridly with a facilitator. The facilitators, we've got 4 facilitators. We're going to split you all up into 4 groups. You'll stay within your hospital, so it forges some of those relationship building and communication between your microbiologist, your paediatrician, your pharmacist, plus or minus your hospital at home nurse. But we'll be amalgamating some of the hospitals depending on numbers and stuff like that. But yeah, I'm going to that will be our next session. And then after that, we'll be setting up our action learning set, our community of practice, and trying to really start moving forwards with some of these QI projects and deciding what we are able to focus on. So, any questions? Judith, is that a legacy hand or is that a new hand?
legacy hand, sorry.
Okay, don't worry, don't worry. Okay, I can't see